Mr. Chairman, dear colleagues. First of all, I'd like to congratulate Professor Dr. Mohsen Ibrahim, Professor Dr. Ragab Abdel and Professor Dr. Hussam Al-Shair, and the whole scientific committee of Egyptian Society of Hypertension on the annual meeting of Egyptian Society of Hypertension. Actually, this is the approach. This is a lecture approach for diagnosis of secondary hypertension. And first of all, we should know that secondary hypertension represents 5 to 10% of hypertension cases. When we talk about secondary hypertension, we should have a cause for the hypertension. So this is the agenda today. Who should to be screened for hypertension, for secondary hypertension, and the approach for the diagnosis of secondary hypertension, and specific feature of the main causes of secondary hypertension. To start with, this is the main causes of secondary hypertension. We have obstructive sleep apnea, the renal causes such as renal parenchymal disease and renal artery stenosis, the endocrine causes such as primary aldosteronism, Cushing syndrome, thyroid disorders, and pheochromocytoma, the congenital vascular disease such as aortic coarctation, and drug-induced hypertension, in addition to pregnancy, which is out of our scope today. So who should be screened for secondary hypertension? Young patient with hypertension, especially if they don't have a risk factor for hypertension, should be screened. The patient with resistant hypertension, defined as blood pressure more than 140/90 despite 3 antihypertensive medication, including diuretics. The cases with severe hypertension and hypertensive emergencies. The cases with non-dipping or reverse dipping on ambulatory blood pressure, and target organ damage, especially if it occurs early in the course of the disease. Actually, also we have some patient that thought to have essential hypertension, and they might have combined secondary hypertension. We will talk about the patient with generalized arteriosclerosis. They might have renal artery stenosis. The patient, those are overweight and obese with resistant hypertension. Obstructive sleep apnea can represent a cause for the hypertension. And when we give our patient some drugs and look again for their blood pressure, what is called a second diagnostic look, we might have an excessive potassium drop with diuretics in cases of primary aldosteronism, or a decrease of GFR with the RAS blocker in cases especially with bilateral renal artery stenosis and labile hypertension, which is defined. We can achieve blood pressure goals. However, this won't be persistent and the blood pressure will fluctuate. So the second part of the presentation is the approach to diagnose secondary hypertension. We start with the clinical background and identification of the clinical clues of secondary hypertension. Again, we should identify which patient to be screened for hypertension, and in addition to some diagnostic clues such as the obesity, snoring, sleepiness in the patient with obstructive sleep apnea, abdominal bruit in the patient with renal artery stenosis, the specific feature of endocrine causes, of different endocrine causes, and in cases of aortic coarctation, the detection of different blood pressure measurement between the upper and lower limb, in addition to the brachiofemoral delay, can be a clue for aortic coarctation. So the first step is a clinical background. It's very important. The second step is to do a 24-hour ambulatory blood pressure. It's very important and very crucial in identification and diagnosis of secondary hypertension. It can exclude multiple fallacies that encountered in patient during office blood pressure reading, such as white coat hypertension. Also, it can exclude the cases of a pseudo-resistant, as the patient repeatedly have a high blood pressure during office blood pressure measurement. However, this was wrong. This can happen with the use of small cuff size, leading to false elevation of blood pressure, or not letting the patient to rest for at least 5 to 15 minutes before measuring the blood pressure. In this case, we might have a falsely high blood pressure. And third is detection of the dipping state. Normally, the patient should have a 10% nocturnal dipping of the blood pressure. However, in many patients with secondary hypertension, we might have a non-dipping or reversed dipping of blood pressure. So this is the first two steps, is to a clinical background, the ambulatory blood pressure, and the third step is to exclude the co-founders of the secondary hypertension, such as this important condition, which is pseudo-hypertension. In elderly patients, they might have a calcified and rigid blood vessels that lead to very high blood pressure reading, falsely very high blood pressure reading, despite little or no target organ damage. When we give these patients drugs, they have a marked reduction of their blood pressure and marked symptoms with the antihypertensive drug. The arterial stiffness of the brachial artery can be identified with a carotid radial pulsed wave Doppler, and we have some clinical maneuver to detect this condition, such as Osler maneuver, which is inflating the cuff of blood pressure sphygmomanometer above the systolic blood pressure, and detecting and palpating the artery despite being pulseless. This is called Osler maneuver. We should exclude the poor treatment control. The poor treatment can be due to poor adherence of the patients to the medication, or the clinical inertia of the physician to up-titrate the antihypertensive medication to the desired doses. Also, we should take a drug history from the patient. We should know if the patient takes some drugs that can be associated with increase in the blood pressure, such as non-steroidal and steroid that can lead to salt and water retention, diet pills, stimulant and decongestant that can lead to sympathetic nervous system activation, licorice that can activate the mineralocorticoid receptor, the oral contraceptive pills that also can be associated with increase in blood pressure, and the chemotherapeutic agent such as cyclosporine, vascular endothelial growth factor inhibitor, and tyrosine kinase inhibitor that leads to a state of systemic vasoconstriction via the reduction of nitric oxide and the increase of endothelin-1. So by knowing that and reducing the dose or stopping these drugs, we can achieve a better blood pressure control rather than diagnosing our patient as secondary hypertension. And the fourth step is to look for every cause and the specific feature for every causes. We should start with the most common cause to the least common causes. Here we have the obstructive sleep apnea, which is relatively common now. As Dr. Azza mentioned, we have a high rate of obesity in our population. And the patient with obstructive sleep apnea can be suspected in the presence of snoring, excessive, exaggerated daytime sleepiness, morning headaches, lack of concentration and irritability, with increased frequency of motor vehicle accident. On clinical examination, these patients will have an evidence of narrow upper way, defined as large neck and the presence of microglossia, obesity and peripheral edema, and with echo we can find left ventricular hypertrophy called pulmonary hypertension, and 24-hour ambulatory blood pressure will detect non-dipping or even reverse dipping with rhythm disturbance such as tachycardia and or bradycardia. This is after suspecting the obstructive sleep apnea, we should screen the patient using this questionnaire, which is Epworth questionnaire. And if the patient is likely to have obstructive sleep apnea, he should go to polysomnography or sleep study. This is an example of Epworth sleepiness scale, which show the daily activity of the patient. And the patient should score his daily activity from 0 to 3. And if the total score is more than 10, the patient have high likelihood of obstructive sleep apnea. Renal parenchymal disease is a very common cause, and it's the most common cause of the secondary hypertension in children, and the second most common cause in adults after obstructive sleep apnea nowadays. It can be easily detected using a simple investigation such as urine analysis, serum creatinine, and renal ultrasound. And this is an example of the abnormality of the renal parenchymal disease. We can have a polycystic kidney or small atrophic kidney that define the renal parenchymal disease. Another example of the main feature is the renal artery stenosis. Renal artery stenosis in the elderly patient can be suspected in the patient with multiple risk factors such as smoking, diabetes. In the patient have generalized arteriosclerosis such as coronary artery disease, peripheral arterial disease, or cerebrovascular disease. And with reduction of the renal function with the use of RAS blocker, also with recurrent flash pulmonary edema. Clinically, this patient might have an abdominal bruit that is suggestive of renal artery stenosis, in addition to an arteriosclerotic disease such as coronary artery disease or peripheral vascular disease. In the 24-hour ambulatory blood pressure, we will have a severe hypertension with reversed nocturnal dipping, and this patient might have a history of flash pulmonary edema. To screen this patient, we can do duplex ultrasonography and abdominal imaging such as CT or MRI, and if the stenosis is confirmed, we can proceed in the angiography in a selected cases such as the cases with recurrent flash pulmonary edema. Also, the renal artery stenosis can occur in the younger patient, and the cause will be fibromuscular dysplasia that will be associated with another vascular abnormality in other vascular beds, such as the cerebral vascular bed. Moving into the endocrine cause, and we'll talk about the primary aldosteronism. It has no specific feature. However, it can be suggested with hypokalemia that is found in 40% of these patients. So not all the patients with primary aldosteronism will have hypokalemia. And the important investigation to be done are the plasma aldosterone concentration, plasma renin activity, and the ratio between aldosterone renin activity. If it's high, and if the ratio is high, we can proceed to imaging such as CT, MRI, and if we need a further study, we can do adrenal vein sampling to recognize adenoma-producing tumor versus idiopathic hyperaldosteronism. And there is an important precautions regarding the measurement of aldosterone renin ratio. We should correct hypokalemia. We should give a high volume of sodium. We talk about giving a patient 2 liters of sodium before the test if it's safe, and to switch to antihypertensive medication that don't have an impact on the test, such as verapamil, slow release, hydralazine, and doxazocine. And the sampling should be in the mid-morning, 2 hours after getting from the bed, and the patient should be sitting for 5 to 15 minutes before the test. The other endocrine features, endocrine diseases, we have Cushing syndrome, which with characteristic feature of moon-faced buffalo hump and thin skin and stria over his body. It can be screened using 24-hour urinary cortisol and 1 milligram dexamethasone suppression test at night. Thyroid disease, either hyperthyroidism and hypothyroidism can be associated with secondary hypertension and can be easily detected through the clinical picture and lab investigations such as TSH and free T3 and T4. The pheochromocytoma is not very common. However, it can be suspected using these 5 Bs, which is paroxysmal hypertension, pounding headache, perspiration, palpitation, and pallor. And if it's suspected, we should do 24-hour urinary catecholamine and plasma metanephrine. If positive, we can proceed to abdominal CT or MRI and MIBG or whole body MRI if the above are not conclusive. So to screen, not every patient should be screened for pheochromocytoma. The patient that should be screened, those patients with hyperadrenergic spells, those who have a family history of pheochromocytoma, the patient with genetic syndrome such as MEN2, von Hippel, and neurofibromatosis, incidental adrenal mass if it's large and associated with cystic changes. Aortic coarctation also with, as we mentioned, with a blood pressure difference and radiofemoral delay is another cause of secondary hypertension. So to conclude the presentation, secondary hypertension represents 5 to 10% of hypertensive cases. We should start with a clinical background, and we should see who should be screened and identify our clinical clues. We should use the 24-hour ambulatory blood pressure and exclude other confounders. And we should move from the causes from the most common to the least common. Actually, it's a detective work that needs suspicion and need to use the available facilities to recognize the patient and the cause, as recognition of the cause will be the way to treat this patient. And thank you so much.
شكرا دكتور كريم.